Hello, my name is Nathaniel Tso, and my presentation is on the effectiveness of technetium Mebrofeninimaging in assessing liver function pre and post yttrium-90 SIRS therapy. Technetium Mebrofenin hepatobiliary scintigraphy, HBS, is used to calculate the ejection fraction of the gallbladder. However, it can also be used to quantify hepatic function for the purpose of liver reserve estimates after portal vein embolism prior to surgery. HBS using Mebrofenin allows for regional assessment as opposed to only a global measure of function that is derived from the standard liver function blood tests. Mebrofenin has a high first-pass extraction. In the first 10 minutes after IV injection, it reflects global hepatic function, and it is therefore vital to calculate the liver function values within 10 minutes before it starts to redistribute into the common bile duct and gallbladder. SIRS is a targeted therapy which uses internal radiation therapy directly to tumors. This type of therapy is called selective internal radiation therapy, also known as SIRT. These beta-emitting yttrium-90 SIRS are used to treat secondary non-resectable liver tumors, such as colorectal and neuroendocrine tumors. It can also be used to treat primary liver diseases, such as hepatocellular carcinoma. The SIRS treatment can either be whole liver, both the right and left lobes being treated, or lobar, either one, the right or left lobe being treated. The SIRS are administered using a small catheter guided into the liver under angiogram, as you can see from the image here. The microspheres are carried by the bloodstream directly to the tumors in the liver, where they preferentially lodge in the small vessels, feeding the tumor and delivering their dose of radiation for a period of approximately 2 weeks. The radiation dose to healthy liver parenchyma following SIRT can result in liver toxicity and, in serious cases, liver failure. This can have implications for treatment planning, which is complicated by a lack of an evidence-based organ toxicity in combination with individual patient characteristics, such as prior chemotherapy and pre-treatment liver function. It is therefore important to assess using Mebrofenin how a change in liver function may impact the normal liver compartment, which cannot always be spared. So there are times where the SIRT dose has to be reduced so we don't cause liver toxicity or failure. This is an example of a functioning liver compared to a compromised functioning liver. The normal functioning liver has good uptake in the hepatocytes, and therefore you can clearly see the liver well defined. However, when the liver is compromised, there is delayed blood pool clearance in the heart. So you can see the heart's still very avid, and therefore a reduction in the uptake of the hepatocytes. And you can see a very badly defined liver. The graphs at the bottom is an example of how Mebrofenin can be used to quantify the measure of liver function. So using Mebrofenin, we can calculate the blood pool clearance and the liver uptake rate as a percentage per minute. The blood pool clearance decreases as the blood travels away from the heart to the liver, and the whole liver uptake increases as the blood travels into the liver. The normal uptake rate is approximately 8.7% per minute. The aim of this study was to assess changes in liver function as measured using Mebrofenin HBS before and after yttrium-90 SIRS liver-directed therapy, comparing patients receiving whole liver or lobar treatment. So all patients being treated with yttrium-90 SIRS between 2018 and 2020. All these patients had a HBS baseline 2 to 3 weeks prior to therapy, and then they all had a follow-up 6 to 8 weeks after the yttrium-90 SIRS therapy. A total of 62 patients were treated and followed up. The dose we use is 200 megabecs IV of Mebrofenin. We acquire anterior and posterior dynamic supine with the entire liver and heart in the field of view. This allows us to generate a geometric mean for analysis. On the table, you will see the parameters we use. And the important thing to note here is that we do a quick 6-minute initial dynamic, followed by a quick spec CT. This is important because we want to gather all the information and acquire the data within 10 minutes. Because otherwise, after 10 minutes, the Mebrofenin will start redistributing into the common bile duct and gallbladder. Analysis was performed using an in-house code in IDL using a Hermes platform, which was first described by Ekman's methodology. The two regions of interest that we draw are the heart, the whole heart, and the whole liver. The Mebrofenin extraction rate was derived through linear regression. The blood pool clearance rate and the T-half, together with the body surface area corrected liver uptake rate, are calculated based on the geometric mean counts in the cardiac input region of interest and the whole liver region of interest following the Ekman's published methodology and in our in-house workflows written in Hermes. This was validated against in our in-house code IDL. So an impaired blood clearance is less than 10% per minute. An impaired T-half blood clearance is greater than 5 minutes. A note here is that the liver uptake rate, PATLAC, is an alternative measurement that is applicable, but it is not published in the literature. It is the Ekman's that is published. The normal liver Ekman's body surface area corrected is greater than 3. If it is less than 3, that would indicate a high risk of liver toxicity. These values are based on Bennick's paper and are considered acceptable. There is evidence these normal values are something that is lacking in the literature, but we are constantly investigating these values at Royal North Shore Hospital. The image on the right shows the qualitative normal and a qualitative compromised liver, which is now also confirmed using the quantitative indices that we've generated. So you can see a normal has a T-half of the 4.7, whereas the compromise had a T-half of 17 minutes. So our analysis was to compare the change in Mebrofenin indices between baseline and post-SIRT for all patients. We also further reviewed comparing whole liver SIRT versus lobar SIRT. The percentage change and significance were determined comparing whole liver therapy versus lobar therapy. So we had different indications of patients. This included colorectal cancer, neuroendocrine tumors, pancreatic cancer, and metastatic breast cancer. The age ranged from 34 years of age to 88. The average prescribed dose for the whole liver treatment, it was 1,081 megabecs. For lobar treatment, the average was 1,421 megabecs. Of the 62 patients, 38 patients had whole liver therapy and 24 patients had lobar therapy. So these table is the results of the patients who had whole liver treatment. And you can see there is a drop in all values from the baseline to the post-treatment. We're looking at the means here. And this drop was significant. These are the results for patients that had the lobar liver therapy. You can see here that there is also a slight drop from baseline to post-treatment. However, it is very slight and it is not significant. Here are two examples of how treatment has affected the liver function. So from example 1, It is a 75-year-old male with primary liver cancer. He had left lobar liver therapy. You can see the pre and post SERT Mebrofenin and how the blood pool clearance and the liver uptake rate have remained very similar. However, in example 2, this is a 71-year-old male with metastatic colorectal cancer. He had both lobes being treated, whole liver therapy, 75% to the right and 25% to the left. You can see there is a big change pre and post therapy in the blood pool clearance rate. It's quite a considerable drop from 21.9% to 12.2% per minute. So 28 out of the 38 patients in the whole liver treatment group had a 4 in reduction, which was significant. There was a mean decrease of 22% in overall liver function in this subgroup, with no significant fall in the lobar group. No significant fall in the lobar group could be due to the spared liver tissues compensating the function or liver regeneration. In conclusion, patients receiving lobar therapy maintain their overall liver function, presumably due to the spared liver compensating or liver regeneration. The whole liver therapy patient group sustained a small fall in function at the 6 to 8 weeks post-treatment. Thanks for listening, and these are the references.